you in whose hands the life of many others would be. So it's not whether you are being graded or not. Doesn't matter. Think about it. There is no exam, but tomorrow you have to treat your friend, your family members, your mother, your brother, your sister. What do you think about it? Would you say that because I was not graded and I should not do that? The real exam is when you step in the surgery room. Yeah. But the real exam is when the patient trusts you. When the patients trust you. And, you know, I feel like sometimes I have goosebumps. Sometimes I have these goosebumps when people share with you as a physician everything, every secret of their life. You know why? Because they trust you. Hence, no, when I say you can treat your family, because that's where it is difficult. That's why you don't treat your own family. It's not that you cannot. You do. People do, and there are many examples that people have done surgeries on their own family members. But the thing is, if you consider everybody as part of your family, your community as your family, okay, that's where it is important. Exam or no exam, grades or no grades, it's your responsibility of the learning. All right. Having said this, shall we start? Okay. Today we will talk about ear. We have two lectures, year 1 and 2. We have 2 hours altogether. So what I'll do, like I would in first hour or so, we'll cover year 1, and then we'll see year 2, which is more of inner ear. Now the objectives of both these lectures will be that you identify different parts of ear, its cavities and contents. And then you relate the structures of different parts of the ear with their functions and clinical significance. Differentiate between normal and abnormal appearance and functions. Okay, both of the pinna and tympanic membrane. Then you explain the anatomical basis of some of the clinical presentations. Okay, at this point in time, we are interested, in particular in this hour or so, from anatomy point of view, that how would you relate the anatomical basis of those clinical features. Now, I want you to look at this particular picture, which is showing us bilaterally right and the left entire hearing system, which starts from outer ear, middle ear, and inner ear. So we have 3 parts of the structure of the ear: an outer ear, outside of the tympanic membrane, a middle ear, which is between the tympanic membrane and the medial wall of the middle ear cavity. So we have something in the middle, hence we call it as the middle ear. Okay, so this middle ear. Then we have a system of tubes sitting inside this bony part of the temporal bone. And this bony part of the temporal bone is called petrous. Petrous comes from stony hard. So the inner ear is sitting there. Okay, inner ear is not a bony in itself that you can take out, like you can take out a tooth or you can take out a phalanges. You cannot take out an inner ear. Inner ear is all membrane. Okay, or we'll learn more about it when the time will come. Okay, does it make sense that what are we looking at? You need to talk to me. Okay, and if you like to talk to me, yeah, you can shout. Yeah, no problem. You can unmute yourself and can talk to me. Okay. Now let's look at this ear. Now what are we looking at? We are looking at the external ear. You see the pinna or the auricle, which is this fold of skin supported by the underlying elastic cartilage, and it is covered by skin on both sides. Okay, it's covered by skin on both sides. So you can see that skin of the pinna is very adherent to the underlying cartilage. So if I ask some of you, okay, to pinch the skin, of your ear, for instance, like this. Can you pinch the skin from your ear itself, from the pinna? Try do that. Radha, were you giving a try? Did anyone else give it a try? Yes, no. I did, but yeah, Sarah did, Mariam did, but could anyone pick up the skin from the pinna itself? All right, you can just hold on. Someone said almost impossible. Someone said I could. Yeah, that's unusual, but you cannot, because the skin is very adherent to the part of the, the cartilaginous framework, the elastic cartilage. Okay. At the edge, maybe, but not most of it. Now, this opening, which is here, is the external auditory meatus. Meatus word is for an opening, external opening outside, external auditory meatus. Okay. Now, this external auditory meatus will take us into this canal, which is the auditory canal. So we have the external ear, external auditory meatus, and then external auditory canal. And you can see that it's around how long? It's around 2.5 centimeter long, and this 9 millimeter is the height of it, and this blue arrow is showing its length. Okay. Now it is at different point, it is slightly narrower. You can see that at this point it is slightly narrow. So this narrow part is called the isthmus of the external auditory canal. Now the innermost limit of this external auditory canal is this membrane, which you call it as a tympanic membrane. Okay. Now, tympanic membrane is the one which is receiving the sound waves. It's like, drum of your speaker or a woofer. Okay, but instead of moving by electrically in your speakers, sound waves are striking onto your tympanic membrane, and that's where it will create the movement in the bones, which are sitting in the middle ear cavity, which we'll see, and later on they will move the different parts of the inner ear so we can perceive sound. Okay. Now these are different folds which are being named. Okay, so you can see that our external ear, it has a helix, a chubby part which is the lobule, and this is the part where people usually put those earrings and other things. Okay, while this one would be then anti-helix. So helix, anti-helix. Between them, it's a kind of a boat-shaped kind of a fossa or groove. We call it a scaphoid groove or fossa, which is kind of a deep. All right. So if you put your finger just underneath your ear, that's where this groove there. Now these features are not necessarily prominent and same in all. Okay, so if you compare your ears with your brother and sister and mom and dad, there will always be slight differences. Okay, now look at this part, which is the tragus. Sitting opposite to this is anti-tragus. Okay, so these are the projections, and in between these two we have the intertragic notch. Now this is a point where it is taking us to the external auditory meatus. And what is passing through external auditory meatus? Can anyone tell me? What is passing through external auditory meatus, where this arrow is now sitting? In living, what is passing through this? You all hear me? Air. That's excellent. Lean said air, of course. Air. But besides that, you can see that you can put your finger in that as well. Okay. So air containing sound waves, dust, dirt, everything. Okay. Sound waves. $1 billion industry. Earbuds. Do you use those earbuds to remove some of the Yeah, we shouldn't be using those earbuds, okay? Because earbuds are the ones which are making these ENT surgeons to have their bread and butter. Because earbuds are troublesome. Earbuds are troublesome, okay? Because they can damage things inside. Now let's look at the nerve supply of the pinna. Now you see there are various, interestingly, when you learn about the development of the ear, so the different sources are coming together and supplying, coming together to form the ear. Hence, if you see the innervation, they are coming from different branches. Look at the part of the skin there, which is supplied by auriculotemporal nerve. Remember, it's a branch of the, which branch of the trigeminal is giving rise to this auriculotemporal? B3, mandibular. It's written there, but you should also understand. Remember, we talked about the auricular nerve, which is coming from C2 and C3. Now you see that most of its external surface is supplied by that auricular nerve. Okay, great auricular nerve. A part of it is supplied by 7th and 10th. 7th and 10th nerve. Which is the 7th nerve? Facial. Beautiful. Which is the 10th nerve? Vagus. Beautiful. Now, if we recall what we talked before, the skin is adherent to the underlying cartilage. What if there is any point of infection, a boil, a pus point? Would it be painful or painless? It would be painful. It will be very painful, as if you are trying to create the gap between the cartilage and the skin. That's where you're trying to peel the skin off, as if you're peeling the skin off from the cartilage. That's why it will be painful. That makes sense? Now you remember, anything which is adherent to the underlying, anything which is connect, which is adherent to the underlying connective tissue, if you try to separate it, there will be pain. For instance, periosteum is adherent to the underlying connective tissue of the bone. If you try to peel it off, it will be painful. Hence, fractures are painful. Burns, superficial burns, when the thin layer of the skin is removed, it will be painful because you're trying to separate these layers. That makes sense? We talked about the nasal mucosa. Nasal mucosa is also adherent to the bones and cartilages of the nasal cavity. Hence, if you try to peel off the mucosa, it will be painful. That's why mucoperiosteum, conceptually mucoperiosteum, sitting in the nasal cavity. Same way, this skin is adherent to the underlying connective, underlying cartilage, okay, which is an elastic cartilage. That makes sense? Does it make sense? Okay. Now let's look at the blood supply of it. Now remember, we don't need to learn every other tiny branch of it, but main branch, for instance, this branch is superficial temporal, and from the superficial temporal, we have the anterior auricular artery. Similarly, we will have anterior auricular vein. From the external carotid, we would have occipital artery, which will also supply partly to the back of the ear, and also we have the posterior auricular artery. That makes sense? So you see, these are these vessels which are basically taking care of the external ear. Now, if we put things together, this is how it will be. So if you look at the ear from outside, you look at the vein, which is the external carotid artery, different branches, the posterior auricular, which is going posterior to the pinna. And then we have the superficial temporal, and from the superficial temporal, these different branches, which are going and supplying the parts of the pinna. Okay, now these are the anterior and posterior branches of the superficial temporal. Similarly, we have the superficial temporal vein, which is draining the veins. Now, see the great auricular nerve, okay, which is supplying the part of the pinna, and also auriculotemporal nerve, right? You see that auriculotemporal nerve, which is a branch from the mandibular division of the trigeminal nerve, is supplying the pinna from outside. Similarly, we have the lesser occipital nerve and great auricular nerve, which are supplying the posterior. This is the posterior surface of the pinna. Okay, now if you look at these different developmental anomalies, Okay, so you can see that, and perhaps Dr. Paul will talk about the development of the face, and or he must have talked to you about the development of the face already. Maybe you will have these lectures later, the development of the special senses. They'll cover the year. Okay. Now you see that all these different anomalies that you see, you don't need to remember you don't need to remember anything actually, but just to appreciate that how these different parts of the ear which are coming from different sources come together to form the external ear. What is the evidence that they are coming from different sources? That is something that we need to understand. Why do we say the external ear is developing from different sources? What is the adult evidence that we have? Think about it. What is the evidence? Sight? Okay. What is the evidence? The folds? No. What is the evidence to suggest that stomach is the foregut, for instance, if I put you this way? If I put this question this way? Nerve, beautiful. Allah said nerve supply. You see the different parts which are coming from different areas, they will always retain their innervation. Remember that. Structures move from one place to the other, they will retain their innervation. Okay, when they retain their innervation, you can always trace them where they are coming from. Interestingly, the same thing would happen if there is pain. The distribution of the pain will also be felt in those areas supplied by that nerve, or there will be referred pain there, which is now if there is a pain in your ear, where else you will feel the pain? We talked about it. I want you to recall that information and put it together. Headache, beautiful. Bushra said headache, excellent. Headache, because it is the supply from the mandibular. Mandibular is also giving the meningeal branches. Okay. Also, the auricular. Someone said about the parotid area, because the auricular nerve, which is supplying the great auricular nerve, which is supplying the area of the pinna, is also supplying the area of the angle of the mandible. Beautiful. So you see that this is how these things would be referred, and this is evidence which suggests that these different parts of the ear are coming from different sources, or at least a part of the skin which is coming from different sources. Okay, that makes sense. Now let's look at the external auditory canal. Now external auditory canal is an S-shaped, which is not a straight tube. We think like it's a straight tube, but it's not a straight tube. Okay, it's an S-shaped, so it's a sinus. So you can see the sinus-shaped curve of the external auditory canal. It is 9 millimeter in height and 6.5 wide. It's around 2.5 centimeter long that we talked about, from the external acoustic meatus, which is at this point, till the tympanic membrane. Now, if you look at its wall, now you can see that outer 1/3 of it is made up of cartilage, while the inner 2/3 is bony. Okay, outer 1/3 cartilage, inner 2/3 is bony framework, which is forming the external auditory canal. Okay, now you can see that the outer 1/3 is directed upward and backward, while the inner one is directed downwards and forwards. That's why we have an S shape or a sigmoid shape, or an kind of bend like a letter S. Okay. Now, carefully look at the skin, which is covering. Remember, we talked about the pinna, and the skin were adherent to the pinna. Now, the skin of the external auditory canal is also adherent to the cartilage and also to the bone. Can you all see that? It is adherent to the underlying bone. Now, what would happen if there is infection of the skin there? Would it be painful, painless, or mild pain, or severe pain? Excellent. So it will, Iman said it will be milder pain. Why, Iman, you say it's a milder pain? While Alanud said it's severe pain. So Iman, would you like to talk to us, please?
Hi, doctor.
Hi.
I'm not sure. I was just thinking maybe because like for the outer ear, we said that if there's a lesion, it's going to separate the skin from the underlying cartilage, and
Yeah.
inside it's not in close contact. Maybe I don't know. I was guessing.
Uh, it's excellent that you are guessing, but let's have understanding. Same way, like we have the skin, which is adherent to the cartilage there. Now the skin is also adherent to the cartilage and the bone. So we have the muco kind of cutaneous junction here. The skin is adherent to the cartilage. Now the skin is adherent to the underlying bone. So if there is any inflammatory process there which is peeling it off, it will be severe pain. Okay, there will be severe pain. Okay, so you see that infection of the external ear, there will be a little boil there, would be very painful. That makes sense?
Yeah, I understand. Got it.
So what is important for the inner, what is important for the pain sensation to travel? What is important for the pain sensation to travel? Innervation. Okay, so we'll see the innervation. Now let's look at the limit, which is the tympanic membrane. This tympanic membrane is an oval shaped, okay, and it is having a thickness of around 0.0. Did I mention it somewhere? It's a very thin kind of a membrane, 0.075 millimeter thick, and different dimensions are tall at one point and wide at the other point. So it's basically much taller than being wider. Okay, and it is concave. Remember that it is concave outwards. It's not flat. Let me go back. So you see, it is concave outward. It's not flat and straight. Okay. Now this membrane is having these different quadrants. So if we divide into 4 quadrants: anterior, superior, anterior, posterior, superior, and inferior. There are different things that you can appreciate on the tympanic membrane. Okay, now what you appreciate there? Okay, now if you see, first of all, this bony process, which is the manubrium of the malleus. Malleus is one of the bones of the middle ear. We have the anterior and a posterior fold. Between these folds, we have this pars flaccida. We call it pars flaccida. Now, why do we call it pars flaccida? Because it is relatively thin. What makes the tympanic membrane at first place? A tympanic membrane or eardrum basically has 3 layers. Outer layer, which is continuum from the skin of the external auditory meatus. The inner layer, which is the lining of the middle ear. In between, we have the connective tissue. Now, this connective tissue is thinner there. That's why we call it the pars flaccida. That makes sense? This portion, which is going all around, is called the annulus. Okay, this is called the annulus. Now, in this area, it is much thicker. We call it as pars tensa. That makes sense? Now, this quadrant there, when you are projecting the light through here to have the otoscopic examination, okay, you see that this part normally should shine. This part, which is in the anterior inferior quadrant, should normally shine. If the concavity of the eardrum is compromised, for instance, instead of being this, it will become straight or bulge out, this cone would be disrupted. Okay, so this illuminated area is important from clinical point of view. Now, normally we see that it is sitting at an angle. Okay, this angle is around at the 55 degree. Okay, but in children, it is even much like, you know, sitting at an acute angle, as if almost horizontally sitting. Okay, that makes sense? Yes, no? So you see, these are the different parts of the tympanic membrane. Now, which nerves should supply the outer surface of the tympanic membrane? All the nerves which were supplying the external auditory canal. Okay, so those nerves will be responsible for that. What nerves should be supplying the inner part? All the nerves which are supplying the middle ear. Okay, arterial supply. Once again, you see that they are coming from the branches of the maxillary artery and the posterior auricular, and also partly from the branches from the middle meningeal artery. These different vessels, which are auricular branches, deep auricular, anterior tympanic, stylomastoid branch, they all get in, and from the periphery, they give these branches which are going radially into the substance of the tympanic membrane, and they are supplying these. Now, interestingly, if you look at the central part is perhaps is the area which is less vascularized. It's very interesting. Okay, it's less vascularized. Now, what would be the implication of a structure which is less vascularized, a thin structure which is less vascularized at a certain part, certain area, certain region? What will be the implication of that? Ischemia, beautiful. Ischemia, and that part can easily rupture. Being thin, having less blood supply, that part can easily rupture, and we'll see it later. Okay, now let's look at the innervation of the external ear, which we talked before. So you see most of it is by great auricular, part by the facial. Okay, then we have the branches of the vagus which are supplying it, and then the auriculotemporal nerve, which is coming from the mandibular division of the trigeminal nerve. While posteriorly we have the lesser occipital supplying that. Now similarly we have the innervation to the tympanic membrane. That makes sense? That makes sense? Ischemia, necrosis, same thing, Ala. Yep. Ischemia will lead to necrosis. Okay. Now think about it. Now you see, if you look at the central part of the, somebody said, if I can repeat, if you look at the central part, perhaps the central part is the one where the blood supply relatively would be less if you compare the periphery. That's why most of these perforation that you will see would be in the central part. Okay, they will be in the central part. Now it is neuro once again. What would happen if you stimulate the vagus nerve fibers which are innervating this external auditory canal? What is the consequence of stimulating the vagus nerve? Put it this way. What are the functional results of stimulating vagus nerve? Nausea, beautiful. Nausea will lead to dizziness, vomiting, beautiful. Nausea, vomiting. All right, nausea, vomiting. What is its effect on our cardiovascular system? Bradycardia. Excellent, bradycardia. So if a person who has heart block, is a history of the heart block, what will happen to that person? It can go to the complete heart block because of the decrease in the heart rate. So it can decrease the heart rate suddenly. Okay, that's why in removing the vex, people usually use a bit of a warm water. Okay, so to de-vex or syringing the ear with the warm water is advisable. Cold water induces the cardiac arrest. How? By stimulating the vagus nerve. Okay. Now, Lean is asking that how do we stimulate the vagus nerve? We are irritating the area supplied by the vagus nerve. That makes sense? This is how we are kind of stimulating the sensation which are going along with the vagus nerve. So if the vagus nerve then responds to it, it will not only be a response to the GI, but it will be a response to cardiovascular system as well. So we do not only feel dizzy if someone pushes, like put a water in the syringe, and if you irrigate your ear with cold water, that's what can happen. Okay. Yeah, during the surgery, usually people use warm water, not the cold one. Okay. Now let's look at the middle ear. Can you all see this matchbox kind of a geometrical diagram? Can you all see that? Irtada? Itada, can you see that? Yes. Now, would you like to explain to us that what are we looking at? Unmute yourself and you can talk to us. You're looking at a matchbox. You're looking at a matchbox and it is giving some dimensions. It is saying it's a floor. If with the floor there, so what will be this area then? Roof. Simple as that. The letter L stands for the lateral wall, and then M stands for the which wall then? Medial. Simple as that. So we have the floor, roof, a lateral wall, and a medial wall. Now tell me what forms the lateral wall of the middle ear cavity? Which structure forms the lateral wall of the middle ear cavity? Tympanic membrane. So this is that tympanic membrane. We see that tympanic membrane is not a vertical membrane. It's kind of a concave, and it is concavity is facing outward. Now we will come to the facial canal. Allah, we will see the facial canal. We will come to the facial canal. Okay. Now this is the medial wall. Where should we see the inner ear? Lateral to the lateral wall or medial to the medial wall? We'll see the inner ear medial to this medial wall. So you can see the different dimensions. You see that? So 15 millimeter height and the 6 millimeter width, 2 and 4 at different places. So it's not kind of a matchbox itself. It's kind of a, having different dimensions at different points. All right, let's look at the middle ear. Contains what? We'll see the ossicles, which are bones. We'll see the muscles, and we see the extension of the middle ear cavity. Okay, that makes sense. We will see the extension. Now, what are the extensions? We will see the auditory tube or eustachian tube and mastoid editus, which is taking us to the mastoid process air cells. Okay, let's look at these ossicles. Okay, now this is that malleus, incus, and stapes. Okay, you don't need to know every bump and bruise of the thing. Okay, you should only be able to identify, well, this is the head of it, this is the neck, and this is the manubrium of it. While this is the body of the incus, a short and a long process. Now this body will have an articular area which will articulate with the head of the malleus. So incus and malleus, they articulate with each other. Okay, while this process I will articulate with the stapes. So let's look at the stapes. Okay, stapes will have a foot plate and an arch, a foot plate and an arch with an anterior and a posterior, crust, which is kind of a leg, and it will have a head, which is called as the capitulum. Okay. Now, anyone does horse riding? Horse riding. Do you do horse riding? Anyone of you? The place where you put your foot to hop on the horse, to sit on the saddle, that is called as a stapes, because that's where you put your foot in. Okay, this is looking like that. That's why we'll call it as stapes. Now, stapes muscle, stapes bone is basically blocking a window of the inner ear, which we'll learn later. Now, let's look at, is it all clear? Does it make sense? We don't need to know every bump and bruise, but the main things. Does it make sense? How many people we have? 182. 182. Can I pick someone from 182 to talk to me, or it would not be appropriate? Tell me. You can, or I should. Abdullah bin Deem. Abdullah bin Deem. Is Abdullah with us? Tahir Muhammad Mufti. Is Tahir Muhammad Mufti with us? No, it's. I'm looking at the participant's name. Abdullah. Your name is Abdullah. Abdullah Zain. Not Abdullah Zain. There was another Abdullah. Abdullah bin. Okay. Tahir Muhammad Mufti. Is Tahir Muhammad Mufti with us? So long you would, watch this letter and learn it. I don't mind. Okay, I don't mind. All right, let's go to see some of the joints. Let's look at these joints. Okay, now look at the malleus, incus, and stapes. This is outside. This is inside. So you can see the head of the malleus is articulating with the articular process of the body of the incus. Now this process, the long process of the incus, will articulate with the capitulum of the stapes, or the head of the stapes. Okay, stapes will have a head, neck, a posterior and an anterior crust, and this is the foot plate. Now these joints are all synovial joints. Interesting, very interesting. These small joints, these are perhaps the smallest bones, and these joints are the synovial joints. They are moving all the time. Okay, that's why. And they are rarely affected by, almost never affected by some of the joints of the diseases, or like osteoarthritis and other things. Now, if we move one bone and a joint, this bone will move this joint, and this will then move the stapes. Now, stapes is the one which is creating movement of the fluid inside, and we'll learn it later. Oh, I'm so sorry, Zen. I'm so sorry about the way that some of the names have been, joined together. Now, do you all understand? Now, let's look at some of the structures which are attached, sitting close to and attached to. Look at this nerve, which is the cauda tympani nerve. Now, you can see that cauda tympani is sitting very close to these bones of the middle ear. Look at this attachment of this nerve, which is called tensor tympani. Tensor tympani. Okay. Now, this muscle, when it is pulled, this bone will become stiff. So this joint will not have any movement. And remember, this malleus, the long process of the malleus, the manubrium, is adherent to the tympanic membrane. So the tympanic membrane will become stiff. So whatever the sound wave will come, will not be able to move this bone. Then it means there will not be any movement at this joint. No movement or less movement means less movement there. So what will happen to the level of the sound that you perceive? Will it increase or decrease? It will be dampened. Beautiful. Similarly, we have another muscle. Okay, we have another muscle which we call it the stapes. Now, stapedius muscle is there. Okay, this tendon, which is the attachment for the stapedius muscle. Now, if this muscle is also pulled, this will also make this joint rigid. So indirectly, you are making this and this joint rigid. Hence, they will reduce, not increase. They will reduce the amount of the sound that you perceive. Does that make sense? So if you make the bones rigid, there is no movement, no sound. Normal movement, normal perception of the sound. Okay. Now let's look at the middle ear. What we have done here. This is a tympanic membrane. So this is outside. This is inside. We'll come to the innervation of the tensor tympani and innervation to stapedius. Sarah, very good point that you have raised. Tensor tympani is supplied by a branch from the mandibular, while the facial is supplying the stapes through. And both these small muscles, which are in the middle ear, are playing a role in dampening the sound to reduce the amount of the sound that we receive. So large bang that you hear first time, second time, the same sound, you will not hear with the same loudness. Why? Because these muscles are pull. That's why after a big bang that you hear, you won't be able to hear anything else, because everything is now become taut and rigid. Okay, now let's look at the tympanic membrane. This is that malleus, incus, and stapes there. Look at this muscle there, which is the tensor tympani, and this tendon of the muscle, which is there of the stapes. Okay, now this is the medial wall of the middle ear. That's where you see these bony projections, and these bony projections are for facial nerve, hence we call this as facial canal. And sitting posterior to that, we have the semicircular canal. There are three semicircular canals in our inner ear, and one of those is the posterior, the lateral semicircular canal, which is projected into the wall of the middle ear. Okay, so this is the lateral wall, this is the medial wall. On the medial wall, you see these openings: oval window and round window, oval window and round window. Now you see the foot process of the stapes is covering the oval window. So the foot process of the stapes is like an oval shaped thing. Okay. Now this is that promontory, which is the raised part in the middle ear, but basically this is from the cochlea. Okay, this is from the cochlea. So the promontory, which is the raised part, is like this little hillock in the middle ear, basically from the cochlea of the inner ear. Now, if you look at the posterior wall there, can you see this window there? Can you see this window there? This is the auditus, our inlet, and this inlet, our opening, will take us to the mastoid sinus. Okay, so this is taking us to the mastoid auditus, and it will take us to the mastoid air cells, and I'll show you later. Now look at some of these nerves which are forming the plexus, which are called the tympanic plexus. So the tympanic plexus is formed there. Okay, look at this nerve, chorda tympani. Remember that chorda tympani is coming from which nerve? Facial. You see that this nerve is sitting in this canal, and it is giving out to this nerve. Now similarly, this little muscle stapedius is supplied by a branch from the facial there. Hence, the damage or paralysis of the stapedius will lead to hyperacusis, as Ghada said, and she's absolutely right. It will lead to hyperacusis, means normal sound loudness heard very big, hyperacusis. Okay, that's why these people get scared of the sound, phonophobia. We talked about it. Now these two muscles, tensor tympani and stapedius muscle, let's look at them with a little more detail. Now, tensor tympani and stapedius muscle. Now this is present next to the pharyngotympanic tube. Okay, its attachment, we saw it is attached to the malleus. That's where the muscle belly and the muscle tendon. This is coming from its own tube. Okay, bony framework. It is coming from there and is attached to that. Now its innervation is, as someone mentioned about, it is from the mandibular division of the trigeminal nerve. Okay, tensor tympani. Look at this tiny muscle there, which is the stapedius muscle, coming from a raised pyramidal kind of process, and is attached to the stapedius there. Okay, this muscle is supplied by a branch from facial nerve. Now you can see the importance of these two nerves, which are supplying these tiny muscles. If there is any problem, these joints will not move, and hence there will be problem in hearing. So you will hear it louder, hence hyperacusis. Does that make sense? Is it making sense? Yes, no? Yeah, it is a facial nerve through branch of stapedius, and this is the muscle supplied by mandibular division of the trigeminal nerve. Okay, nerve to tensor tympani is coming from the mandibular division of the trigeminal nerve. Now a simplified version of the different walls. So you see the roof, the floor, the anterior and the posterior wall. What is removed here? The lateral wall. What is forming the lateral wall of the middle ear cavity? Tympanic membrane. So once we remove the tympanic membrane, we see all these. Now look at the medial wall. You see the promontory there, and then you see these two windows, an oval window and a round window. Oval window and a round window. What is covering the oval window? Which bone? Stapes. Excellent. Footplate of stapes. While this round window is covered by just a membrane, and this membrane sometimes we call it as secondary tympanic membrane. Okay, so we have the primary tympanic membrane outside. This is a secondary tympanic membrane. You can see the canal in which the facial nerve is sitting. That's why we call it the prominence of the facial canal that you can see there. And this is the lateral semicircular canal. Okay. Anteriorly, you see this opening, which is taking us to pharynx. Remember that we had pharyngo-tympanic tube or eustachian tube. So it is connecting the middle ear to the pharynx. While this opening there, which is auditus to the mastoid antrum, will take us to the mastoid ear cells posteriorly. So you see both anteriorly and posteriorly we have extensions. We talked about this pyramidal process, and attached to it is a stapedius muscle, okay, which is attached to the stapes. Look at this cauda tympani nerve, which is been cut, which is running across the middle ear. Hence, if there is a problem of the middle ear, what will happen to the taste sensation if this nerve is compressed? There will be, if not loss, there will be altered sensation, basically reduce, okay, sensations of anterior tooth or other than correct. Look at this vessel there, which is internal jugular vein. So there will be kind of a bump there. Okay, so there will be a kind of jugular bump there in the floor of the middle ear cavity. All right, let's look at this there. That's where you see the roof, floor, lateral wall, and a medial wall. And this is where the posterior wall is. And anterior wall is removed there. Okay, anterior wall, which is facing towards us, is removed. This black window, remember, is taking us to the mastoid antrum. All right. Now, if you understand all these, it will be simple to look at any complex diagram. Look at this nerve, which is the facial nerve, and you see that it is passing through the petrous part of the temporal bone along the boundaries of the middle ear. Okay, that's why this nerve is prone to damage if there are problems of the middle ear cavity. Okay, that makes sense? Now, this is another diagram. You can repeat at your own time, and it won't be difficult to understand a seemingly complex, not very complex diagram. It's a relatively simpler diagram that you can see. So this is the lateral wall. It's like a box that we have created, and we have opened up the box. The lateral wall is down now. We have opened up the box. So you see the floor. You see the jugular bulb there. This is the medial wall, and you see in the medial wall the oval window and the round window there. Okay, and on the oval window you can see this stapes bone, and you can see the tendon of the stapedius muscle, which is coming from the prominence there. Okay, that's where the facial nerve is sitting, facial canal, and this is that lateral semicircular canal, which is also making a bump in the medial wall. The roof would be the floor of the middle cranial cavity, and this is the eustachian tube, which is coming from the anterior wall. So this wall there is the anterior wall. Okay, sitting next to this, we have the internal carotid artery in the canal. So there will be internal carotid or carotid canal. Okay, while posteriorly, remember what was sitting posteriorly? This area there is the auditus to the antrum. Okay, so this diagram is a simplified diagram with these structures. Now let's look at the eustachian tube. You see that this tube, which is connecting the middle ear cavity, which is this space there, to the pharynx. What is the function of this eustachian tube? Tell me what function you can assign to this eustachian tube. Pressure. How do pressure balance, equalizing pressure? How do you balance the pressure? What helps you to equalize the pressure? Pressure of what? Air. Beautiful. The air pressure. So it's the air pressure. So it's the aeration of the middle ear cavity. Okay, so it equalizes the air pressure on the same side of the eardrum. So we have the pressure of the air on this side and pressure of the air on this side, because the middle ear through this eustachian tube will open into the nasopharynx, and nasopharynx is opening outside. That makes sense? That's why. Now, if you look at the angulation of this, it's not sitting horizontally. It is sitting at an angle of 45 degree. Okay, but in infants, its angulation is slightly different. Now, I want you to carefully look at this tube as well. Remember that we talked about the bony and the cartilaginous part of the external auditory canal. Similarly, we have the bony and the cartilaginous part of the eustachian tube. So let's look at the eustachian tube in little more detail. That's how it is. So it has a bony part and it has a cartilaginous part. The narrow part in between is called the isthmus. Okay, so lateral 1/3 bony, medial 2/3 is cartilage, fibrocartilage. That makes sense? Now see the opening here. That's where it is open. Okay, and this opening is the one which is opening in the nasopharynx. Let me show you the nasopharynx. You see this opening there. So interestingly, this cartilaginous part is not a complete circular structure like this. It is a C-shaped structure like this. Do you see that? Can you see that? C-shaped like this. Beautiful. It is kind of like a valve. We'll see that. We'll see that. True. Okay. Now, this opening there is a muscle attached to it. Now, this muscle, which is attached to this part of the eustachian tube, is a tensor palatini. Tensor palatini. So when we use the tensor palatini muscle, you must have learned in your GI the swallowing mechanism. When do we use this muscle? When do we use the tensor palatini? During mastication? When we swallow, beautiful, at the time of the swallowing, because we want the food to go down in the oropharynx and down in the laryngopharynx and into the esophagus, not back into the nasopharynx. Hence, we shut the connection between nasopharynx and oropharynx through the soft palate, and the palate has been now tense. So we have a tensor palatini. So when we use this muscle, okay, now you see normally what will happen when the tube is open and when the tube is closed. Okay, so you see what is happening to this configuration of the tube. When we open the tube, and so in picture B, when the cartilage hook is actioned by the tensor palatini. So when we swallow, the tube is kind of open. Otherwise, it remains kind of a closed, because then there is a continuous air pressure. Because when you are swallowing, can you swallow with your open mouth? It will be difficult. Okay, you can do that, but it will be difficult. Hence, when you use the tensor tympani muscle, which is during the time of swallowing, the tube opens. Okay, it kind of uncurls, like it is curled here, and it opens like a valve. Somebody mentioned this as a valve. It's because of the hook shape. Okay. Now it says because there is no food going into the nasal cavity. There is no food going into this nasopharynx. Okay, nasopharynx is present in the area of the eustachian tube is present in the area of the nasopharynx. So this palate there, when it is shut, okay, when it is shut, it is close a space between the air space and the food space. No food goes up there. Now what if the palate is not developed? Like in case of cleft palate, what will happen to the infection of the ears? Otitis media, excellent. Hence, if you look at the eustachian tube of a child and that of adults, that of the child is short and more horizontal, And when these child are suckling the bottle and they're sitting and lying on, not sitting, lying on one side while suckling, it is easy that the milk can trickle from the eustachian tube into the middle ear cavity. Milk will go into the middle ear cavity. So what will happen then? Otitis media, middle ear infection. That's why middle ear infection are common in which age group? Infant. Beautiful. Let's look at this bone there. Okay, it's a temporal bone, different parts. You see the middle ear space there, and we have this pterygotympanic or pharyngotympanic or eustachian tube. This is the auditus, and this is the area of the mastoid antrum. Now, this space continues forward, middle ear, and also posteriorly. And posteriorly, we have the mastoid ear cells. So you see the infection from the middle ear can spread to the mastoid ear cells. Otoscopy, you will learn, or you must have learned, or you will learn in much detail. Why are we pulling the ear to examine the ear? Why are we pulling the ear? To open the canal, because remember we talked about the sinus-shaped, S-shaped course of the canal. So just make it straight so we can see through. You can see what is sitting inside. Vex is the common problem. Okay, Vex is the common problem. Infection of the external ear. I do not want you to remember everything. You had a separate lecture on the different problems of the ear. Okay, otitis externa, different types. Otitis media. Would the otitis media be painful or painless? Will be very painful. Anyone suffer from the earache? People say unless you don't suffer from toothache, earache, and birth, delivery itself, okay, you will never feel that pain unless you have that pain. Okay, different way that otitis media will look like: hyperemia, bulging, and perforation. Finally, drainage. Okay, and this is how a serous otitis media will look like. Okay, and remember that we were talking about the central part, which is easy to rupture. This is where it can rupture. Okay, and this could be because of the hairpin that you put in, or sometimes those earbuds. Okay, you can look at the perforation due to chronic otitis media. I do not want you to remember everything, but have an idea that tympanic membrane, why it is painful. Okay, now look at these bones. Everything is covered by mucous membrane, and this mucous membrane is continuous with the pharynx. Okay, this is continuous with pharynx through which tube? Eustachian tube. Beautiful. So pharyngitis can lead to otitis media. Rhinitis, inflammation process of the nasal cavity, can lead into the otitis media. That's why you see they are all connected with each other. Okay, not only the infection, sometimes these foreign bodies, you see, you can put these beads or bees inside. That's why some of the toys, most of these toys will say that people under certain age group should not be given these toys because they are too small. They can put those pieces of the toys in their mouth or nose or ear, hence the age limits. Okay, trauma. Someone said, how would a bee get stuck? It's very common, Sarah. It's very common that some part of the world, there are different parts of in Australia where they grow onions. In those areas, there are lots of bees. People need to cover their heads like with a mosquito net to cover themselves from those bees. They can easily get into flora and fauna. All right, that makes sense. Now, these are some of the tubes that you must have learned in your clinical session, that if there is continuous infection, you can put these tubes there, so there is air passing on both sides of the tympanic membrane. So till that point where the infection is completely healed, with the time these tubes, kind of be replaced, or they can just fall off. Look at this complication. This is the mastoid process. and the infection can spread to the mastoid process, and there could be abscesses and rupture, which will lead to the fistula. Okay, so you can imagine that how everything is connected from the nasal cavity to the eustachian tube to the middle ear to the mastoid. From middle ear outside, we have the external auditory canal. Okay, I'll stop here, and we'll continue in the inner ear next week. All right. Thank you very much. If you have any questions, please let me know. Chorda tympani is a branch which is supplying the tongue. It joins the branch of the mandibular, which is the lingual nerve, and it will supply the anterior two-thirds of the tongue. Palatine muscle, when we swallow, the palatine muscles are helping us to make the palate stiff and straight. That's where the palate is. The palate is lifted up by different branches, and it's also become stiff. So that stiffness is by a muscle, which we call the tensor palatini, and this tensor palatini is attached to this tube, pharyngotympanic tube or eustachian tube. Okay, I'll stop here. Thank you very much, Mice. We would like to close the meeting. Okay.
Thank you, doctor.
Thank you very much.